Yes, sir. Mike Dobbins, Dora Petzkowski, Sasha Black Fox Qualls, Danny Callison, Julia Coates, Joe Deere, Kevin Easley, Lisa Hall, Johnny Kidwell, Darrell Legg, Kendra McGady, Cody Poindexter,
Honey.
Joshua Sam, Mike Shambaugh, Melvina Shotpouch, E.O. Smith, Condessa Teehee. We have a quorum.
Thank you, Shelley. If you had time to look at the minutes, I would entertain a motion to approve. Motion is second. All those in favor? Okay, motion passes. For reports, again, we have Captain Murray that's here for George Valier for the Claremore Service Unit.
Good afternoon.
Good afternoon.
Thank you for letting me have a few moments with you today. You should have the report, as always. If you have any questions about that, I'd be happy to either provide clarity today or go back and find the answer for you. I do have 4 different bullets for updates to Claremore, activities we've been doing over the last 30 days since I've spoken to you last. The first bullet, Dr. Gary Lang was our clinical director. He retired after 33 years of service at Claremore Indian Hospital. So it was very exciting for him, a loss for us, of course. But Dr. Nix was named acting clinical director on December 27th. Dr. Nix has been the chief of emergency medicine at Claremore Indian Hospital since 2014. He completed his residency in emergency medicine with OSU Medical Center in 2014 and began working at Claremore as part of an Indian Health Service scholarship payback. He completed the payback in 2018 and has continued his work at Claremore. He graduated from OSU College of Osteopathic Medicine in 2010 and Oklahoma State University in Stillwater in 2006. He has been married to his wife Annie for 20 years, and together they have 8 children. Dr. Nix is a citizen of the Cherokee Nation. Okay, next bullet I have is a process we're working towards to standardize with Cherokee Nation Health. We contracted with Resource Corporation of America. They do benefit coordination. They will help search our register of patients and verify if we have health insurance documented for them. They go out and search and will bring in any we don't have, add it to our system, allows us to generate additional revenue and put more money back into the service. So we're excited about that. The contract is active, and their staff, their contractors, are going through the background investigation now. We hope to have it up and running within the next couple months. On January 7th, the Cherokee Nation and the Claremore Indian Hospital participated in a collaborative learning experience aimed at introducing Cherokee Nation's leaders to the current operational processes of our surgical services in Claremore. This half-day meeting provided an opportunity for each working group to learn and begin to establish professional networking and relationships. Participants explored various areas including clinical, preoperative, postoperative, and central sterile processing, which is essentially all of the surgical processes within the hospital. Those familiar or unfamiliar with the facility were given a tour of the building and its clinical departments after the meeting. Lastly, Claremore Indian Hospital has been selected as one of the 4 recipients of the 2024 Every Woman, Every Baby Perinatal Orientation and Education Program Scholarship. It's provided by the Association of Women's Health, Obstetrics, and Neonatal Nurses. This scholarship includes 21 participant seats and provides an opportunity to enhance perinatal nursing education. The scholarship grants access for 3 years to the scholarship resources and delivers evidence-based clinical education to perinatal nurses. The facility can establish consistent educational support for provision of high-quality care for mothers and newborns. Thank you. Any questions today?
Questions for Captain Murray? In your report, Captain, at the bottom of the first page, it says there's 8 provider vacancies out of 39 positions. Is that kind of a about where it is normally, or does that ebb and flow?
It definitely ebbs and flows. It may be slightly high right now. We recently had 2 doctors in the last 4 months, give or take, retire in our adult medicine clinic, primary care. Right now, we're staffing those with locums while we continue to recruit and look to hire those positions.
Most of your locums in Tulsa area?
Correct. Yep.
Anybody else? Danny?
So when you have people with us looking at, in the process of assuming taking over the Claremore Indian Hospital, when people do leave, do you hire those with the intent that they will fit in with the nation, or is the nation involved with the hiring on that, or is that still your operation as you go along?
So technically, it's the operation of still the Indian Health Service. However, we have a team with Cherokee Nation, myself, the director of HR, and 2 Cherokee Nation leadership staff that go through every hiring access with us right now to make sure it matches up with the staffing metrics for Cherokee Nation Health. Absolutely.
Mike?
Do you know how long, or if there is one, a waiting period to get in to see the dentist there? Have you have any idea about that?
I don't off the top of my head. I wouldn't think it's too long, otherwise that would have landed on my desk prior to now, but I'd be happy to find out for you.
Okay, yeah,
Is that for an adult or pediatric patient? Because it varies a little bit.
everything.
Okay, sure,
Adults,
absolutely.
mainly adults, but
Adult.
check on,
I'll get
check
both
on
for
kids
you.
too. That'll work.
Yep.
Thank you.
Not a problem.
Sasha?
Thank you, Chair. I just want to make a comment. Congratulations on receiving that award. That's
Yes.
quite a, that's amazing.
Thank you. I'll accept it on behalf of our staff. They're the ones that earn that credit.
To my knowledge, that is awarded to only 4 facilities in the entire nation and, or the U.S. So congratulations.
Thank you.
Great work. Again, you're making strides there in your OB department. As an OB nurse, I'm proud of y'all. That's great.
Yes, thank you.
Great
That
job.
department is amazing. They do a great job, really care about their patients.
Thank you, Chair.
I appreciate it.
Okay. Thank you, Captain. Appreciate the report.
Yes, thank you for your time.
Okay, Cherokee Nation Health Services, Dr. Steve Jones.
All right, well, good afternoon. Your report is in your packet. I do want to make a comment about, and this, of course, our report is in the rears, so one of the things that I want to acknowledge is that we had the largest number of babies delivered in a year this year. We hit 997. We were really hoping we had hit that 1,000 mark. We had a big celebration planned if we could hit that 1,000th baby in 1 year mark, but we didn't quite make it. But it was really close, and to our records, as far back as we could find, there was never been a year that we've delivered more babies than we did this year. So congratulations to our staff, and it shows, again, the choices people make to come to us to deliver their babies. So just want to acknowledge that. Construction continues as planned. We are, in some cases, ahead of schedule at Salina. We're actually going to be finishing that project ahead of our completion dates. There will be some dates named shortly. I don't know that those are all out yet, but we're looking like we're 2 to 3 months ahead of schedule. So that's a rarity these days in construction. The weather has set us back a little bit, but not really as much as you would think, because we're so close to, and everything's happening inside right now. So that's a big plus. Hospital's on track. All the other planned projects are tracking according to where they should be right now. Let's see. Claremore, we continue to work through, as Captain Murray said, or Commander Murray said, that we're working through as collaboratively as we can. We have people embedded that are helping to work through some of those processes to make sure the metrics line up, so in the future when we take over and compact that facility, we're not working through as many challenges. Some of the things that are challenging, that are difference between what we do and what federal facilities do, is as simple as licensure. And you don't think of that being a big deal, but for Cherokee Nation, we mandate that all of our providers have Oklahoma license. And so that's not always the case in federal facilities. So we're letting people know as far in advance as possible, anybody that intends on staying with us and becoming a provider in our services, that we have the opportunity to get that Oklahoma license and get those accreditations that where they need to be. So those are some of the collaborative discussions that are going on, making sure our job descriptions align, because those things, once they fall under us, will fall under our policies and procedures, and we need to give everybody absolutely as much time as possible to meet those criteria. So that's some of the collaborative efforts that are going on right now. Other than that, I'll answer any questions.
Questions? Joe?
I was just seeing if we had any progress on that OSU partnership in North Tulsa with that area.
To my knowledge, we're still working through some challenges there. We've had some meetings with the providers in that area at the different facilities, and we're still working through some challenges in that area. So there's a lot of people that are vested in that community, and a lot of medical personnel that already have existing facilities that are going on right now, and of course we're trying to alleviate their concerns that we're not there to take over or put them out of business. We're there to add and help, and so some of those conversations are taking place right now.
Danny?
Yeah, Dr. Jones, I noticed in your budget modification, you're trying to get this, is it Cerner?
Cerner?
Yeah, I noticed it. Is there any update on when that would be? Because, I mean, I understand that the program currently at Claremore Indian Hospital doesn't mesh with the one with the Cherokee Nation, so we don't always know what the doctors have said about the patient over there coming to our facilities. So is there any update? Will that be into effect before the October, or is that something that we'll do after we take over?
So Cerner is the electronic health record. That's the company that owns it. It's actually called Millennium, and it's owned by Oracle now. So Oracle bought Cerner out a couple years ago, and so we deal with Oracle, but you'll see it listed as Cerner because that's the parent company of EHR. Yes, we are working toward a deadline of having that in place. The bigger challenge is how much historical information gets moved over from RPMS, because it has to be migrated over and it has to be put in a different format to be migrated over. It can't just go, you can't just connect the two and they talk. So that's the bigger challenge right now. So we're working through those things of how much historical information we're going to try to migrate over and still meet our timeline. The other challenge is we have to look at it as a new health facility. So once we take possession of it or compact it, every patient there is new to us, even though they have historical knowledge. So we'll be putting an effort together, probably starting around May, to notify as soon as we get cross-reference patients. If we're able to get that information and see how many patients already have charts with us, that's a plus. So we're not going to ask them to make new charts, but anybody that doesn't, we're going to start trying to meet with them, put patient advocates in that area to set up times that patients can come through preemptively and get charts made so that they're ready to go on October 1st, and they'll already have a chart made in our system, because that information has to be basically set up anew because they're a new patient to us. Yeah.
Sasha?
Dr. Jones, just curious, with the OB department and the increase that we're seeing and the reason for the hospital expansion, with NHS and other surrounding hospitals being on divert quite frequently, do we know how many of those were due to outlying sources being on divert?
I don't have that number off the top of my head. We do, when they do go on divert, obviously they divert those patients to us and we take care of them in our facilities. So I don't have a number off the top of our head on how many of those patients were outside in divert. There was a period of time where divert was happening quite frequently. Mm-hmm. It seems to have slowed down, and it only happens now on those times when it's harder to staff, like on weekends and holidays. but there was a time when it was more frequent than it is now. I think they're starting to get their OB department under control.
Okay, thank you.
Melvina?
But, I know contract health is a big thing, and will that still be through where you have to call in, like, within so many hours to, when the patient?
If it's outside of our system,
Uh-huh.
yeah, that's not our rules, that's the
Federal.
federal rules on that. So yes, that'll still be in place. We're starting to have those meetings between their contract health and ours to understand how things are so different and how we're going to manage that moving forward. So we're not there yet, but we're starting to those preliminary meetings.
Okay, thank you.
Hey, Doc, how is our dental programs doing? Are we full staffed on all our clinics?
The last I saw, we had 2 providers at Stillwell that left recently. One had a family issue and moved, and the other one had a business opportunity and left. And to my knowledge, we're still recruiting for those 2 positions. We typically have PRN within our own system that fills in when we have a gap. So in other words, we work 4/10s, most of our providers, so on the day that they don't work, they have the opportunity to work an extra day, pick up another shift, be paid additionally for that, and that's how we're filling in the gaps when we have them. So right now, that's the only ones that I'm knowledgeable about that I know we have a vacancy at.
We had a conversation a couple weeks ago, or a month ago, and I was telling you about being approached by 4 people who, it's taken them 6 months to up to a year to get into certain clinics in our dentistry, and that's something that's, I think, pretty widespread. I don't know what the issue is, if we just don't have enough, or if our facilities can't accommodate the number of citizens that we have, or, I mean, obviously we've grown so much and the demand is very, very high. Is there anything we might be able to do to address that?
Well, supply and demand is definitely an issue, and we've expanded and expanded. We expanded our footprint at Oshaleta. We've expanded in Nowata. We have a dental clinic where we've never had one before. We have more chairs, so to speak, or operatories than we've ever had in the history of Cherokee Nation. And it's like anything else. The bigger we build it, the more people keep coming to it. And unfortunately, dentistry isn't something where you just see a patient and write a prescription or treat an ailment and move to the next patient. Typically, there's procedures that go along with that. So you only have the capacity for so many new patients each day. And so what we try to do is have time set aside for those new patient exams for every provider every day. And that limitation is what we're talking about. There's only so many. Once you get in our system, once you have an exam appointment, once you started your treatment, as long as you maintain and come in for your checkups and do things like you're supposed to, you never have to go through that process again. You get to continually stay in the system. You'll have your recall appointments set up for you according to what your needs are, whether it be once a year, every 6 months, every 3 months, whatever it is that your specific as a patient need. Now, every single facility has emergency care every day. So if you have an acute issue, if you have an emergency that needs to be treated, you can come into any facility any day and they will work and get you in. You may not get in right away because they're going to work you in, but they will see you that day, even if it requires them staying a little later at night. We do that. So that's always been the policy, and we've adhered to that since I was running the program years ago. So.
Well, I don't know the answer to that. I just tell you that I know that when people say that they can't get in for 6 months for things, and they're pretty straight up, they're not exaggerating, or even some of them said they couldn't get in for a year in certain places, and they named 3 different, clinics. So, that is something that we're probably going to have to look at in some way, shape, or form. But switching gears, one thing that really has, I don't get it why we don't, but, and I've had numerous calls about this, is dialysis. Well, we don't offer that And, you know, that kind of blows my mind in that, you know, that's the biggest affliction of our tribe is diabetes. And we're having to contract those things out, and people are calling saying they're having to drive long distances to go to dialysis all the time. And, you know, I think that if something was a killer of our people like that, I mean, why don't can we get dialysis centers set up? Can we do something for the people? Because, you know, it's just like our court system. You know, if you only have one court system in Tahlequah, it's hard for people from Kenwood, Stillwell to show up to Tahlequah for court. It's almost a losing situation where if you can't afford gas money to get there. And it's kind of that way with dialysis. You're talking about people who are of higher age. They don't make a lot of money. They may not have reliable transportation. They have to actually buddy up with people to get there, and they try to, you know, partner up with somebody who's making that trip the same day. I mean, I've talked to numerous people who this is a major issue for our tribe, and gosh, I would just hope that we might be able to think about getting some centers opened up. And I know we're talking about money. I know everything costs, but you're talking about the biggest killer of the Cherokee Nation people.
So we started a dialysis program inpatient last year, and we're still developing that inpatient dialysis program. Outpatient, it's a little more complicated. It kind of falls in the same lines as long-term care. It's very difficult for us to find our space in that place. The good thing about dialysis is that once you are deemed to need dialysis, you fall into a category that makes you automatically disabled, which allows you to have external funding to help pay for some of those services. And typically there's companies out there that are co-located all over Cherokee Nation, so we work with them to help find patients those resources. But we don't typically right now have it inside of Cherokee Nation Health anyway.
Is there any way that could change? I mean, you know, you're still talking about elders and people who just aren't that mobile to make these long trips. That's difficult.
Yeah, I agree, and I'm not saying it can't, because everything's possible. It's just, there's challenges to overcome.
I think that needs to be looked at.
It's just like anything else that we do once we start expanding into that space. It's challenging to offer it across the system, because that's what we try to do. When we look at expanding something, we want to know how is that going to help everyone and not just a limited few. And so that's kind of the litmus test as we look at service lines and what we can expand, and then how can we sustain that and not open it and then create an expectation, not be able to meet that expectation. So those are some of the challenges that we look at it every time we look at any kind of service line, whether it be rheumatology, cardiology, urology, anything that we bring a partner in. One of the first things we ask is how are we going to maintain this over time so that once we start it, we don't have to pull back at some point and pull away from it, because that expectation gets created, and we want to meet that expectation.
Yeah, I'm not so sure it's just a small group.
Yeah.
At all.
And I'm not saying it's a small group, but I'm talking about any.
I understand, but
Yeah.
we're talking about this specifically. We're not talking about just anything.
Yeah, no, I agree with you.
So, yeah. Do what? Oh, I'm sorry. Okay, thank you.
Yeah.
Sasha.
Piggybacking on Speaker Shambaugh, adding these services, it would be similar to what physical therapy, occupational therapy, we don't have those at each individual clinic, but if we kind of piggyback on those services at those clinics to expand our service line.
Yeah, in physical therapy, we do try to have physical therapy at every clinic. That's something that we started trying to expand, and we're currently trying to expand occupational therapy and speech pathology to every clinic. Because again, once we start a service line, we want to expand it out to all of our clinics. So we're working on, and some of the challenges is finding the professionals that will go to those locations and work. And so, but we're constantly looking at how we can get that expectation out to all of our clinics, not just a limited 1 or 2 clinics. In some cases, like dentistry, for example, we went for years without having dentistry at Nowata, and it took us a long time to get to that point where we could add that service by adding to that building. I know in some of our facilities, we're limited on space, on where we can put those services in. So we have to look and figure out how does this going to fit and how is it going to fit into the footprint that we already have. Because just like in dialysis, there's certain requirements that you have to meet, and as a nurse, you know what those are. There's infection control requirements. You can't just put it anywhere in the clinic. It has to be in areas that meet those requirements. So there are challenges other than just what immediately looks like on the surface to get from A to B. It's not that we're not open to it, and it's not that we're not looking at what decisions we make on what service lines we expand. For the longest time, cardiovascular disease has been the #1 killer of our patients. And so we've worked hard to bring in neurological services and cardiovascular services inside our own clinics and have the ability for our providers to have those resources available, so when a patient presents to our hospital, we have that backup that we can keep those patients in our hospital. And for the longest time, those patients were immediately transferred out. There was no keeping them in our health system. So it is that we're looking at our data to decide what is the next thing that we put on the table to start working toward, and we do that one step at a time. It's not a shotgun approach to look at anything and everything. We do have a method to how we prioritize and look through, and it's not to say that dialysis is not high on the list. It's just that it takes time to work through these challenges to meet those needs.
Real quick follow-up. Well, is there any way to partner with some of these entities who offer that? And if we can provide a space and that type of space that is clinically sound, I mean, that would maybe one way to do that, since they've already got the equipment as a partner with people, and we can bring them into different locations so, people don't have to travel extravagant distances to get it, because it's a every week deal.
Yeah, and we do look at that and look at partnerships all the time, obviously. We have a partnership. It's kind of a loose term of a partnership in Salisaw. There was a building on our campus that a dialysis company rents that was built way prior to me being in this position, and we support them by, I think recently this group voted to put a generator on their facility to allow them to have redundant power. So we do look at how we can help our community partners when we can.
Thank you.
I think we had to put gas in that generator too.
I think you're right. And
But overall,
I think we also maintain that generator, so.
That's been quite an ordeal.
Yeah.
But overall, that has really been a great thing for Sequoyah County. That I think they do a double shift in the days and evenings. But if we ever do put any more into it, we'd have to be a little more, decide what we're going to do before we start it, shouldn't we?
Right.
But it's helped a lot.
But it's not us running it.
I know.
It's DaVita that runs that.
We've done more than what we went out of our way to be good to them.
Yeah, to help them provide services for our citizens, yes.
We appreciate them.
Kendra?
Yes, I just wanted to say that I'm really pleased that this conversation is even being brought up, because as a public transit director, I can assure you that the logistics and the difficulty of getting individuals to and from these dialysis appointments is a big challenge. Public transit is experiencing shortages in staff like everyone else is, and I can speak comfortably for all the providers for the Cherokee Nation when I say that. So I'm glad to hear us having this conversation, because it isn't just that it's every day. I mean, you can't miss. You can miss once or twice, and when you have to take these extremely long trips and sit there throughout the day and then come back on a public transit vehicle that could be bumpy, I mean, you never know what it's like. So I'm really pleased to hear these conversations being had, and thank you, Speaker, for bringing that up. Thank you.
What else? Dr. Jones, did you say that all of our providers, do all of them have to have an Oklahoma license?
Yeah, we have now I'd say that locums typically, we have exceptions for in some categories because it's a temporary type situation. But for permanent hire and in all the cases that I'm aware of, our bylaws require it. And so our providers, our medical staff has felt like that's important to them as a group, And so they voted, and they are the ones who govern the bylaws. And so our medical staff has made that part of the bylaw process. I think they did that about 5 or 7 years ago. It's been quite a while ago when they made that determination that that was what they were going to have, as well as board certification. We don't require board certification in every capacity, every position that of providers, but the majority we do. And part of that is driven because of the educational requirements if we're going to provide rotations. So those providers that are involved in rotations, either with medical students or with residencies and things of that nature, are required to be board certified. So for future expansion and future opportunities to partner, our medical staff felt like that was important, and they added it to the bylaws.
So if we have a new hire out of Kansas and they relocate in Oklahoma, is there reciprocity between Oklahoma and Kansas, or do they have to?
That's up to the provider they do get a grace period to get that done. And that's why we're working with Claremore right now to help them understand what our bylaws require. And there is, like I said, there is a grace period. So, but that's up to the provider. That's between the provider and their licensure, not necessarily Cherokee Nation. It's not as simple as it used to be, in years ago, like in dentistry, you had an Oklahoma license. If you wanted to practice in Oklahoma and you had another state, you could file for reciprocity and the board would decide whether or not they would give you an Oklahoma license. Now there's more regional testing facilities, and so you go to regional testing if the board requires that. And I'm not sure about the medical board, how stringent they are, but the dental board's pretty stringent on what they allow as far as an Oklahoma license.
Johnny?
Hey, Dr. Jones, thanks for being here today. Just to circle back on something we talked about last month, I believe, have you been able to get in contact with the folks at the Chickasaw Nation about their pharmacy drug program? And if so, what did you find out about that?
I have, and they run their program through their commerce department, which is typically what we would call CMB on our side. There's a lot more to it, but I'll leave it at that, and if you'd like to discuss it further, I'll be glad to sit down and discuss it with you, but that was the gist of it. It does not fall underneath their health program at all, due to some of the rules that I explained to you earlier.
Any other questions for Dr. Jones? Thank you for your report today,
Okay.
Dr. Jones. Up next, Public Health. Lisa Pivek and Dr. David Gann. I do not see either one of them. Ms. Chukalate. Yep. Hi, Kim.
Hello, everybody. Happy New Year. I'm sitting in for Lisa today, and she sends her apologies for not being able to be here. The report's in the packet, so I don't know if anybody has any questions. One thing to highlight, the Wings race schedule is still being worked on, and we will have 18 races through the reservation, so a few more than normal, so that's good. So there'll be more opportunities for people to get out and walk or run or be a part of those. So does anybody have any questions? Yeah.
Melvina?
Yes, it is. Yes, it is. Right, prevention, yes, ma'am.
Kendra?
Well, I just wanted to make a comment, and thank you for being up here. This is the second time I've got to see her. Kimberly's actually from Veneta, and we spoke recently, and she offered to take me on a tour of the wellness centers, and I am really looking forward to that and want to thank you for that as well. So.
And speaking of wellness spaces, if I may just take a minute, as Dr. Jones mentioned, Salina's rolling up, and so it'll be moving a little quicker than expected, so we will have a wellness space there. And then our Stillwell site will open in the probably late spring, maybe early summer for Stillwell. So those are very exciting to have those opportunities for people to utilize those spaces. Very excited.
Mike?
And I think this is correct. Salina is going to have their own rehab too, aren't they, now? Because before we didn't have a rehab area at Salina Clinic. They had to go to Veneta. They got to get shipped out for rehab. Are they going to have their own rehab there in the new clinic?
In the clinic?
For physical therapy, yes.
Yes, yes. All right, good.
I was
Good
thinking
deal.
that was
Thank
correct, but I didn't want to speak
Yeah.
incorrectly.
Thank you.
And it was a space thing before.
Yeah, I know it was. Yeah.
Sasha, did you have something?
If you don't mind to stick around, I just wanted to follow up on something we spoke about briefly
Okay.
previously.
Yes, ma'am.
Thank you.
Yeah, no problem.
Anyone else? Thank you, Kim.
Thank you.
Thank you for your report. Okay. Old business, none pending. New business, none pending. The next meeting is tentatively scheduled for February 10th at 1 o'clock. Are there any Health Committee-related announcements that need to be made? Certainly good to see Counselor Coates here. Didn't see her being interviewed on TV, but I know she's in the middle of it. I need one more motion. All those approve? We're adjourned.